Hello and welcome everyone to our speaker series with Anna Nicholas. My name is Luke DeJesus. I'm the Membership and Engagement Officer here at Palliative Care Tasmania. Before I introduce our wonderful speaker, I'd like to go through some housekeeping for today's speaker series. The nature of the topics we discuss can sometimes raise some complex, powerful, and more emotions for you. So we encourage you to keep checking in with yourself today. During the presentation, we may pose questions for you to respond or to engage with. Your active participation enhances the speaker series experience, so feel free to join in the discussion whenever you are ready. We will, however, have 15 minutes at the end of the presentation for any questions that you may have. If you think of a question during the presentation, you can submit your questions via the Q&A function on Zoom. This is just located at the bottom of your Zoom window. I will be monitoring this section and I'll make every effort that we can to answer the questions within the 15-minute period at the end of the session. But those questions that may not be able to answer within the time frame, we will be doing something on Palliative to make sure that they are answered and addressed. I'd like to respectfully acknowledge the traditional custodians of the land of Nicoluna, on which I will gather on today, and the Palwa people, paying our respects to their elders past, present and emerging. Sovereignty has never been ceded and it always was and always will be Aboriginal land. We recognise their enduring and beautiful connection to this land, water and sea which sustains us all, and honour their traditions of respecting the living, the dead and those who grieve. As mentioned, every speaker today is Anna Nicholas, and I might hand it over to her now to do a bit of introduction to herself and what today will look like.
One. Okay. Just checking you can hear me. Sorry, before I start. Sorry, thanks. Welcome everybody today. I'm Anna Nicholas. I'm currently working as a palliative care CNC at the Royal Hobart Hospital, and on and off for the last 3-4 years I've also been running an end-of-life care project which involved rolling out a statewide plan to improve end-of-life care. So today, look, I'm just letting you know I'm going to do a very generalised talk about improving end-of-life care. And I would imagine from people that are attending today, there's going to be a varied group from acute care nursing to community health nursing, specialist palliative care nursing, residential aged care. There may be some consumers and different people attending. So I'm going to talk about some generalised concepts. It's always quite difficult to completely nail everything. So please, as I said, keep your questions and we can answer them the best of our ability. Throughout the slides, I am going to slot in a little round around my end-of-life care plan. There are quite a few slides, so some I will skip over. And also you obviously have access to the talk once it's loaded up. So just to let you know that. So today, as I said, we're talking about improving end-of-life care from a general perspective. I have worked across all campuses. I've worked in residential aged care. I've worked in community. I've worked in acute care, and so I feel like I have a general understanding of the general concepts, and I think, to be honest, a lot of them are very similar no matter what sort of area that you work in. Now, why is that not working? Sorry. Oh, okay, quick. That left key? Yeah. Yep. Sorry. So basically today we're going to talk a bit about, I suppose, best practice and the concepts, I suppose, when I see patients, no matter where I am, looking about what I suppose, encapsulate when I'm doing my assessments. And I think the key things that I sort of think that we need to really be looking and focusing on is the ability as clinicians to identify the dying patient, I'm going to go through a few small communication tips that are really important for both family and the patient. When I use the word family, I'm just going to be very clear. I suppose it's chosen family. It does not necessarily at all mean blood family. They're the people that provide the ongoing, absolutely essential support to support the people that we're caring for that are dying. And then just look very briefly at the actual management of the dying patient. So looking at identifying the dying patient, things as a clinician that I would be thinking about is I think we need to unravel the sort of mystery or the concept. I think that palliative care definitely has changed. We are definitely, when I started back in 2000 at Royal Prince Alfred in Sydney, I think definitely we were seeing, maybe 80, 90% of people we were seeing were sort of often actively dying, and sometimes not very well. And the other thing is predominantly they were cancer patients. Now I can tell you in 2024 at the Royal Hobart Hospital, we probably are seeing 60% cancer patients now and 40% non-malignant patients, which includes a large component of the frail, aged and elderly. So I just want to have a look at some of the things I would be thinking about is what can be reversed. The other question is what should actually be reversed. Looking at the overall prognosis of the patients that we're looking at, the general goals of care. So the goals of care, there's two components to that. There's obviously the goals of care that are very important for the patient, like personal goals. And also, I suppose, the goals of care that might be around the medical goals of care and the concept of what's appropriate to treat and not treat. And do we think that they could die potentially whilst they're under our care? The other thing I suppose is really important in our role is really looking at the benefit and burden of everything we're doing. I think we certainly cannot be ageist. I think at every step of the way we need to be really looking at considering things like patients or clients in the community comorbidities, looking at their pre-morbid function, their age, their cognition, and as I said before, the goals of care. We often see, I think, sometimes, unfortunately, in the acute care setting, at times very frail elderly patients that at times potentially are significantly very unwell at a baseline and come in and have, very active treatment or interventions commenced, which at times may be very appropriate, but I suppose at times also potentially with good communication and explanations, there might be doing due diligence maybe to go for a comfort approach and not actually start the IV antibiotics or go to theatre. So I think that they're really important considerations, but again, I'm not saying we need to be very considerate in our decision-making processes. And I think the other thing is that we need to look at every individual case separately and make good clinical decisions around the parameters of looking at those considerations. I think the whole way along this journey and for the people we're seeing is absolutely paramount around this concept of really good communication concerning the plan of care for the people that we're looking after. And the other thing I feel, one other take-home message today is I think simple explanations are very good. I think sometimes at times as clinicians, if we can be quite anxious or apprehensive, we may revert quite often as clinicians to talk about, very big languages and concepts that might be around metastatic disease. It might be around pleural effusions. It might be around APO when people have gone into overload. And I think using more very simple, broad concepts and simple language like the cancer has spread very badly now and things like that are really important. So I think we need to really consider in our community things like people's level of health literacy. I think we're seeing a more culturally and linguistically diverse, which is fabulous. And I think all those things need to be considered for the people that we are caring for. I think despite all that as well, we know when people come in and families come in, they are very often frightened, they're overwhelmed. And we know that when that happens, people often, their ability to absorb information is a lot less than when you're having a general conversation, not in this stressful situation. Considerations, I suppose, for the patients and family, I think particularly around place of death is really a consideration that I think that particularly having worked a lot in the community, but also now working often in the acute care, is really looking at the overall picture. It's absolutely vital. I think considering what the patient wishes are very important. Many people may consider that they would, for example, like to have a home death. I think the overarching considerations for this are quite large, and many, I suppose, considerations need to be taken into account. I think the predominant one, I suppose, particularly leaving the hospital, is who are these particular patient, who are the people supporting them, and how much support do people have at home? Because predominantly, despite great support from service provision plus community nursing and specialist palliative care, ultimately a lot of the care does fall onto people supporting their loved one at home, and at times this could be difficult, particularly for people who have complex symptoms such as bowel obstructions, an agitated terminal delirium, or very uncontrolled pain. We have got other options in our community. We're very fortunate. There's the palliative care unit at Whittle Ward, which is a 10-bed unit, Gibson unit, which is supported by some of the medical oncologists and haematologists, residential aged care facilities where people often have lived for a long period of time and considered to be their home. And obviously some people will choose or also be too unwell to leave the acute care setting. Just going to talk about some of the practical priorities that I would be thinking about as a clinician for consideration. And this, again, whether you're working in a residential aged care, in the acute care setting, or, people that are being cared for at home. I'm just going to try and be quick. I've got here the goals of care form. Let's see if I can do this. Yep, I did it. The medical goals of care form is a statewide form, which actually really a lot of people online would be familiar with this form. It really outlines the goals of care or intent of medical treatment for our patients. This form is legally binding for the hospital. It's legally binding for ambulance transfers and for community patients. I'm just letting you know, I suppose, with my thing is most people that we are then seeing with the goal of care is palliative care would be goals of care here C, and not for MET calls or for not for escalation of care, or D, they are dying, which would be in their final days of life. I need to go back. Or how do I go back? Oh, there we go. So quickly going back to this, I suppose I'm going to show you a bit of my end-of-life care plan if they're in the acute care setting. I think a high priority is ceasing and rationalising of people's oral medications. They can become burdensome, difficult to swallow. People are often got symptom burden like nausea and fatigue. So trying to cease their medications that are not clinically relevant for their end of life. Commencement and charting of end-of-life care medications, both they may be regular and also PRN medications. Consideration of a syringe driver, which we'll talk a little bit about. And I suppose then again, very appropriate communication with either the GP or it might be the community specialist palliative care team, and again, consideration of the multidisciplinary team that you may be working with. That might be occupational therapy, social worker, all those sort of things, critical people. I'm not going to talk about these all at length today because I literally could do the 45 minutes just on talking about them, because this is an overview and we can hold some questions for the end. So I showed you the goals of care. So just showing you very carefully, I suppose very quickly, the end-of-life care plan that is currently being trialled statewide. This is currently being used in the acute care setting for people who have been identified as dying, and we would say are expected to die in hours to days. And so basically they need to be goals of care D to commence the care plan. I think the other thing to be very clear about, I suppose, about this end of life care plan that I wrote is it's not a formula that we can just sort of tick and set and forget, that basically it is a guide to help prescribing and directing care, particularly for people working in non-specialist areas, and to guide people after hours. It doesn't replace appropriate clinical reviews and appropriate medical or nursing care. It really is a guide to guide people. How do we identify that people are dying? Just a few things, I suppose, again, as a clinician, when I go to review someone and people are asking me, what sort of things are we looking for? So I suppose 4 key things that we could be looking for identifying dying that may validate this actual process, because even for me, having done it for a long time, it's not always clear cut. And as we are seeing, particularly, as I said, more people with non-malignant disease, at times it can even be blurrier and more complex. So I think a big, massive one I just want to talk to you about is function. I think people that have very poor function, spending a lot more time in bed, having difficulty maintaining their own ADLs, particularly it's a poor prognostic indicator. If they've significantly declined very quickly, it's a poor prognostic indicator. I think investigations, we need to look at whatever might be relevant for that disease process. You know, for a person that's got advanced cancer, it might be around, you know, raised calcium if they had widespread bone disease. For someone who's got a worsening renal function, you know, that's got renal failure, it might be, you know, a decrease in, excuse me, an increase in their creatinine and a decrease in their EGFR. So I think that's very indicative depending where the patient's heading. I think the other thing is prognostication. Again, generally, sometimes it's hard to get right, but I think, again, it's looking at the general prognosis of the illness trajectory of that patient. We might know around heart failure or widespread metastatic lung cancer with brain mets and liver mets. We know people often may not do well. And I suppose, again, we'll look at, I'll show you a slide in a minute, but around physical examination, I think it's completely underestimated. I think examining the patient and getting a very good assessment as a nurse can really give us quite a good picture on how a patient is tracking. Here's just a slide that looks, I suppose, at some of the general body functions as people start to deteriorate and may tip into that sort of final, terminal phase or tip into the phase of dying. So we can see people might have a reduced oral intake and have difficulty swallowing. They may become more drowsy and become less conscious. And unfortunately, and we'll talk a little bit later about this, that they may unfortunately develop a confusion or agitation. Sorry, I don't know how to go. An agitated state. Their breathing may change and develop terminal secretions. And we, particularly with the terminal secretions, we see this a lot in people's final hours of life, which can be quite distressing for families. People may become incontinent that have not been incontinent, or also when people are tipping in with things like reduced renal function, they may have a reduced output. They may become cold. Their skin may become mottled or blue in colour and quite patchy. And we may see people become more hypertensive, tachycardic and edematous. So basically their blood pressure may drop, they may get a faster pulse rate, and we may see more general limb edema or swelling in their arms and legs and tummy. And we often see this with people with advanced illnesses such as heart failure, respiratory failure, people with very advanced cancers. It's a very poor prognostic sign. Just quickly again showing you the care plan that we've developed. It really here is showing on section 1 of the care plan. It looks at the different potential symptoms that patient may be experiencing asking clinicians to tick whether there's a yes or no they're present, and then what medications that we would be encouraging for them to be prescribed to notate on here. Down the bottom, we're really looking at, again, at evidence of advanced care planning, which we know is very important. Not everybody has them, but particularly things like advanced care directives. Do they have enduring guardian? Do they wish to be an organ donator? Or body bequest. Sometimes these things have been well organised, and at times, sometimes they haven't been. So it's just giving people the option and things to consider as clinicians. Again, the care plan here is looking, I suppose the communication section is really looking about where people may wish to die and where is their preferred place to die and what's important for that patient and family. I think the other consideration, again, just to say, is that at times, unfortunately, as much as we would also wish to support people in their choice, for example, to die at home, if we have caregivers that are very distressed or people have very complex symptoms, at times this may be difficult to navigate and something that we may need to engage in having those conversations to take away from families and carers who might be difficult for them to have those conversations, because previously they may have, I suppose, made a commitment to their loved ones to be at home, and that's not always possible. Obviously saying that to the best of our ability, we always try and ensure people get to die in the place of their choice. I'm going to move on a little bit to some communication sort of principles and talking a bit about things that I would be thinking in our clinical practice that might be, I suppose, good language to use, and just, I suppose, some, not Anna's 10 top tips, but I suppose things to think about that are quite important as clinicians. I don't think often people ever mean, of course, to say the wrong things, but I suppose sometimes, choosing our words carefully can make quite a big difference. So I suppose often people are already very overwhelmed or feeling quite frightened about palliative care. So I suppose using words, I suppose, when we've started to become involved about things like, palliative care are going to come now because we're stopping active management, we're withdrawing care of your dad, we're actively palliating. I think they're all things that often can, I suppose, give quite frightening or, I suppose, overwhelming undertones of, oh my God, I've been very, strongly connected with the oncology team or the haematology team, or the renal clinicians, those sorts of people. So it's very difficult, I suppose, considering our language and thinking about things like the focus on now, Debbie, is keeping your dad comfortable. The nurses are going to do regular checks, and our focus is definitely on their symptoms and comfort. The important thing now is about people having time and quality time with their family and close friends. And important to find out, I suppose, what if time's short, what was important that they were hoping for. So I think it's sort of it's also being realistic, but changing the focus and using words, I suppose, that sound gentle and comforting without sort of, I suppose, this sort of like quite direct cessation of treatment, which I think for a lot of people can be incredibly a bit overwhelming and confronting for patients and carers, particularly as we are receiving now so quite a few, younger referrals, which is an amazing thing to be part of, but obviously I think can be very confronting, but can be confronting for any people at any age. I think this sort of ask, tell, ask principle is about really just checking in with people, giving them some information and then stepping back a little bit. But I think one thing that I often do when I go to the bedside is checking in, I suppose, about what, if the patient can answer, what do they understand about their illness? Because sometimes you might, one, save yourself a lot of time because the patient and the family might be very on board with, I've got a poor, that they understand that they're very sick and time is very short. The other complexity on the other flip side of that is when people maybe have not heard the message potentially about how unwell they are, or maybe, I suppose, really struggling to come to terms with what's happening. And maybe I suppose, there might be quite a big mismatch in, expectations around what's happening. I think once we've clarified that understanding, I suppose it's also is working out, now that they understand what's happening, what is important to them. And I suppose really pulling together the realism of what's happening in a very sensitive way is very important. And sometimes, as I said, that can be quite a complex situation. It's about working as a team and people being on the same page and supporting each other as clinicians to come to the best, I suppose, understanding for the patient that we can make happen for them. I think we need to understand, I suppose, also that sometimes when this happens, that it will come with emotion. So they expect, I suppose, when people maybe potentially really take home the message from what you've explained to them, is that there could be a lot of sadness, a lot of tears, there may be anger. I think anger and aggression are very different emotions. I think sometimes anger, a distress comes out in anger. It's not excusing poor behaviour, but I think sometimes, very clear, empathetic statements and support can often just de-escalate a very sort of distressing situation for people at times. The use of silence, and I think just being in that space and really giving people time is really important. I suppose tips that I think are really important from my own personal experience that I've learnt is that I think particularly we need to really get a really good history about our patients and our families, and often use the families to get a good history about what would be important for them. The patient may lack capacity, so we can't always rely on decision-making coming directly from the patient. I think we need to use a very individualised approach, which is very sensitive. We need to foster connectivity with that patient, it's vital, and the family, acknowledging their concerns. And I think sometimes we maybe undervalue, not always, but I suppose, sometimes a little bit in the acute care setting, the knowledge base and asking families and significant carers about the patient, particularly if they might be confused or delirious, getting a really good history, what makes them, what do they love, what makes them more settled, what were they like, what were their interests. I think those sorts of things are really important. As I said before, I think in 2024, we have seen vast leaps and bounds in palliative care and how it's changed. So I think to say that everybody that we see in my role is really just death and dying is not the case anymore at all. And again, I think sometimes a trial of therapy at times may be appropriate. The other thing I would say, I suppose, particularly for people that may be working in things like, I suppose, residential aged care settings, is having the ability to have sort of, conversations about limits of care. Would we treat Bill with a trial of oral antibiotics for his chest infection or his urine infection, knowing that he's been living there very comfortably for 4 or 5 years with his advanced dementia, which is a life-limiting illness, and would otherwise, if there was an improvement on the oral antibiotics, would we keep him there for comfort? As we know, sometimes moving people into that acute care setting can just add to that confusion and distress. But again, I think we need to look at the individual case. And looking ultimately, I suppose, we know when people definitely are being treated on a palliative care trajectory, The overarching goal of care is to treat and manage distressing symptoms. And we shouldn't lose sight of that. Even sometimes it can be quite complex. Just going to skip over that. So just quickly, I just want to talk a bit about some of the nursing care things. I think really, again, some of the things I would be thinking as a clinician, people working sort of in the clinical field, is what symptoms for our patient would we need to be managing now and into the coming days and weeks? What are things we know when people, for example, have got unfortunately a delirium, we would need to, have appropriate both, non-pharmaceutical and pharmaceutical options to support them in their final days of life. We need to discontinue the non-essential meds. Our preferred route for delivering medications for end of life definitely is the subcutaneous route. We'll talk a bit about that in a minute. What interventions could we stop that have been unnecessary or burdensome to the patient at the end of their life? Because we know often that can happen. Regular symptom reviews by everybody that makes up that team. So that team could be, our assistants in nursing, it can be our enrolled nurses, our registered nurses, CNCs, medical team, allied health. Everybody comes to the table and has a role to play. We've talked a bit about communication and education and how important that is for family to really support them through this, at times, very complex time. And we've talked about the goals of care and the place of care. In my guidelines for the end-of-life care plan, I'm just letting you know there are some prescribing guidelines. They are guidelines, they are not policy and procedure. And it's up to the individual, clinician, to use their discretion and look at the individual case to guide you in prescribing for end-of-life care. I'm not going to go through all those medications today, but just to say, I suppose, on the whole, for people who are dying, I think best practice would be to ensure that people have morphine, midazolam and haloperidol at least prescribed for end-of-life care. The two notations from that would be that hydromorphone may replace morphine if people have renal impairment or a true allergy to morphine. And haloperidol definitely would not be clinically indicated for a patient who has any Parkinsonian syndromes, as we well know, clinically not contraindicated. So just a couple of quick things, I suppose, more general clinical considerations, I suppose, is I think basically we often do use syringe drivers at end of life. What are considerations around our drivers? I think that we know that when we give people a steady state of medication, that often they might have a more therapeutic benefit. We can put multiple medications in together. It may work out geographically that at times can be difficult to access people, but also may give people the opportunity to be at home. Some younger patients do find a syringe driver a little bit, I suppose, confronting or a little bit problematic. The other thing, I suppose, from a clinical perspective is to consider that we don't see it as a sort of a set and forget project. I think with the syringe driver, it's basically when we start the driver, we need to be doing regular clinical reviews or getting regular feedback from, it might be from the nursing home or the GP or the family members about how things are going since the driver's connected. We know that when a syringe driver started, it can take 6 to sort of 12 hours to reach steady state. So the patient may need regular top-ups or PRNs for at least the first 6 to 8 hours until it's reached some sort of steady state. From a nursing care perspective, things, again, I think that we're all familiar with, but I think are essential to remember is that our patients, if they're in the hospital, should be definitely potentially in a single room. If they're at home or they're dying at home or they're at a residential aged care or anywhere, if possible, often being in a hospital bed and air mattress may be able to reduce the chance of pressure injuries and ensure more comfort. We've got the principles of regular mouth care, which are essential, and eye care. We probably see this one more in the acute care setting, but removal of any non-essential attachments such as ECG dots and cannulas and things like that. Skin care, which is important, and continence. I think there's definitely many cases where people, I think for energy conservation and skin conservation, may receive or have an IDC inserted. There's also some cases where people may have a trauma history or it might not be clinically appropriate and they need to be managed appropriately with pads and regular checks. As all skin does, it's absolutely important. I think for turning and for the patient that's at home, patients that are dying, I suppose the other thing is I would suggest for family members at the nursing home or for any ward nurses who would be sick of hearing me say this. But I think on the whole, when people are dying, before cares, often 30 minutes before, we would give a dose of either morphine or hydromorphone and midazolam to ensure their comfort and least distress as possible when we're moving them. Regular mouth care is important, and again, it's absolutely vital that we're supporting the chosen family and carers who at times will be fatigued, distressed, needing a lot of support, and really are amazing people to often keep people home in very tricky circumstances. The principles of prescribing for the palliative care patients, just very quickly to go through. I suppose, again, I think we want to move away from the sort of, I suppose, connotation that because people are dying, they always need large amounts of medication and they need to always be very sleepy. I think what I would say my principle is that we need to give the least amount of medication with the best effect. So we want symptoms well relieved, but at times we know it's also very important for people to be able to engage at end of life, have important conversations and to interact with the people around them that they love. What can we de-prescribe and rationalise? We've talked about being very clear clinically about people's history and allergies, looking at the benefit and burden of what we've prescribed, and working with local pharmacists and ward pharmacists, if clinically appropriate, to support the appropriate charting. I think on the whole, just if people are not familiar, that best practice is that these safety intimate butterflies that we didn't have before, that sort of are inserted like I suppose a cannula type principle, that come out that only have plastic left in the patient, are the most in the preferred choice of administration of our medications. We don't use intramuscular. We rarely use IV, and preferably these safety intimate butterflies are the best for use for best clinical practice. On the whole, this is the positioning of the body parts. There's no particular one that's right or wrong. I just want to be very clear, I suppose, is we don't put butterflies into anything that's swollen, just because we'd be very not sure, I suppose, about their absorption or ability to absorb. Never over bony prominences and away from ports or pacemakers or things that might be in the sort of upper sort of chest. If people are confused and agitated, we may place the butterfly, at the back of their scapula. That can be a bit uncomfortable, but it might be the only choice if people, unfortunately, are quite confused. Doing a time check. Just quickly about the symptoms, I suppose one of the biggest symptoms we see and manage all the time is pain. We know that 75% of the people that we look after will need a strong opioid when they're dying. What I think we need to take away from this, though, is the importance of looking at simple causes and not taking away from things like, urinary retention, people that might be constipated and uncomfortable, people that might have a bony prominence on their heel that's causing a lot of problems. So not undervaluing and estimating the importance, again, of very good articulate assessment, but also just saying that I think what we would often, unfortunately, at the end of life, a lot of our patients will need regular analgesia, and on the whole, we would use morphine, hydromorphone, or at times for complex cancer pain or complex pain, methadone. All patients with regular analgesia will always need PRNs written up. That is best practice. And I've drawn my passion is about the preemptive analgesia is essential prior to movement. I'm not going to go through all the drugs, but I just wanted to let you know there's a little bit of a guideline for looking at people that I suppose for prescribing around opioids. And I suppose our bread and butter drug that we often use would be morphine. But I suppose the other drug we're seeing a lot of now definitely is hydromorphone. But I think what I would say is we need to be very cautious and remember that hydromorphone is very pertinent, relevant to be used for people with renal impairment, but also it is 5 times stronger than morphine. And the other thing, I suppose, just looking here is about our conversion rates to say is that we know when people come in that are very unwell, who have been on oral medications like oral morphine, and we're changing them to subcut because they can't swallow anymore, is if we're going from oral to subcut, we basically need to halve. And if we're going from subcut to oral, we basically need to double. But we do need to look at the clinical scenario in front of ourselves because it can vary from case to case, particularly people who are frail aged or have renal impairment. We may be more cautious with our prescribing. So I've talked about hydromorphone. I just got two or three more slides. I suppose wanted to flag that I think delirium is a really complex symptom at the end of life care that we see with a lot of our patients who are dying. There are many reasons, and they're listed here, why people may tip into a confusional state. And I think, again, it can often be multifactorial and complex. We know people that die, unfortunately, with an uncontrolled delirium. It can have quite long-reaching consequences for families and carers in their bereavement stage. So it's really important that we really ensure that people with delirium are treated appropriately and ensure they have a dignified death. It's really important. Non-pharmacological management of delirium, just a few things here. Again, we're talking about really involving the family, looking at the environmental things like reducing noise, single room, having family present, having music, involving things like it might be involving animals being with them. They're just as important as the pharmacological components of treating an end-stage delirium, which can at times be quite distressing for families, and it can be quite a complex symptom to manage. So I've given, again, a bit of an overview there of pharmacological drugs that we would use. Look, they're all off-label, and people come with very varying experiences and anecdotal preferences, consultants nationally and worldwide of what drugs they would use. In Hobart or Tasmania, we would use haloperidol, and for worsening deliriums, we may use some levomepromazine. And a lot of people would be very familiar with midazolam and clonazepam in the benzodiazepine family. I think we can't underestimate, though, this non-pharmacological approach. It's absolutely vital that they both go hand in hand. Just quickly about secretions, because I'm conscious that I've got about 2 more minutes. I think chain stoking is respiratory secretions is a normal process in dying. There is very limited actually academic evidence to say that anticholinergics, the ones that a lot of people would be familiar with would be glycopyrrolate and buscopan, that they are super effective in my reading. I think what we would say is if people start to hear that sort of noisy breathing, is to give the drugs if they need to use them very quickly. But the 2 main things are the bottom 2 points in this slide. Is the most important thing is positioning patients on their side often. And the last main point definitely is supporting and reassurance and education for families, because it can be a very distressing symptom. And particularly if it goes on for hours to days, it can be very confronting and not pleasant. So I think these 2 last points around positioning side to side and support for the families are absolutely vital. This is my last slide. I think it was around the care plan. It's a symptom assessment tool that we use at the bedside, which I suppose is a bit like an ADS chart, but really looking at people's symptoms, severity score around pain, restlessness and secretions, which staff can mark, and then also down the bottom looking at other... How do I go back? How do I go back?
Oh, can you click onto the slide?
Back. Yep. So, this is formulated to basically help improve and document around effective, I suppose, symptom management of patients that we're caring for dying. Ideally, I think this chart would be great to roll out eventually into aged care setting and into the community sector. And it's a bit of a longer term project of mine, which I think would be quite valuable for improved clinical care and outcomes for the dying patient. I think this is another thing, sorry, we will distribute it to you. It's probably my bad computer skills, but a form that I've developed, I suppose, around care in the last days of life. And it really is a very, very simple form that explains to families about what happens when people are dying, around their circulation, breathing, sleep, that they're, around what happens. And again, people are more than welcome to take that and use that. It's very simple and it's pitched at a very good health literacy level for people to understand. And I think sometimes it just backs up a good conversation that's required, particularly if people are coming and going from houses or the residential aged care or the hospital. I think the last thing we've talked about before also, I suppose, is considerations around place of care, which we've talked about. I think that's really important. And I know in the future there'll be further discussions, but just to say that we do have our CPAC service now, which is a specialist palliative care service coming, that is able to facilitate and support residential aged care, which is a great new incentive that we have had over the last couple of years with really positive outcomes. And I think thank you for today. I think we're all doing the best we can to support the people that are at their end of their life. I always suppose was last point, I suppose, with people that when I'm doing my teaching, often I say that I think we've got one crack at this, a bit like when I think people have babies. We have this big, massive thing about birth plans and getting it right and the music and all the rest of it. And I see that being part of people's end of life journey with their family and the patients is just as a bigger privilege. And we need to do the best we can in the circumstances we're in at the time to ensure that they have the best death possible, because they're the things that the families and the loved one people, they will remember that for a long time, your care and considerations that you've given to them. So I hope today was helpful. Might open it up to questions and Hope that was helpful.
Awesome. Thank you, Anna. That was a really informative presentation, and I loved your last kind of comments there around the key and importance of making sure, the death is right. We do have some questions here in the chat. If you would like me to, I can read them out to you, or if you're happy to go through them yourself, whatever's easiest for you.
I can read one here that says, what is the most common question you're faced with on a daily basis? Oh, right. Oh. Look, I think a lot of people, particularly away from the patient that's dying, a lot of people definitely who want to know, they feel guilty about asking, but they often want to have a bit of an idea around timeframes. And one question I'd say around the timeframes is always being very careful and a bit guarded around giving advice around timeframes. You don't want to sort of say, someone's got, 2 days and they live 7. So often I might say hours or days or weeks, unless I think I can completely nail it, which sometimes I have been doing it for a long time. So people often want to know because they will need to get people over from Melbourne or Brisbane or, Launceston or Burnie. So a lot of people ask that. A lot of patients actually are quite frightened and want to actually know about the dying process. And I think we just need to be guarded about going into the absolute nitty-gritty of that. But I, again, with our communication, would like today, the last week I've been looking after a very young person and, of course, massive fear. And I think what I would like to reassure them that all of us working in this arena are giving our damnedest to ensure that they will die comfortably with the right medications and the right support to the best of our ability. It's not always easy and I would really strongly suggest to people from their facilities or wherever is to reach out to palliative care. And look, sometimes that comes with its own complexities. GPs may feel, of course, I'm just saying, for example, that they do the job very well, and lots of GPs are fabulous. And maybe other GPs also are very keen to involve palliative care because they acknowledge that they want that support. So, I hope that sort of answered the question. I'm sorry today, I've literally done the sort of A to Z of palliative care in 45 minutes. So if I feel like I've tried to do it justice, but I was really just trying to pull a few key snapshots of things that I think are, I suppose, important. But certainly I could talk about it for 14 days in a row and still not cover everything. I'll just check if there's other questions. Okay. How do you support the family of a patient when they are unwilling to accept the stage of dying their loved one is at? Any advice when you see family conflict? That's really difficult. I'll answer the first bit, support the family of a patient when they're unwilling to accept the stage of dying. I think it's really trying to get them on side. Both often the patient may be very distressed and or the family. And look, it doesn't necessarily have to be just young patients. It might be, the patients come in for their 7th admission with COPD that's as stoic and gutsy and never thought they were going to die. I suppose, again, it's a lot around things like rapport building, giving them simple pockets of information very clearly. I think thinking, if I can swear, you're actually shitting me on the inside and I just want to tell you that you're dying is actually going to get you nowhere. It is fairly disrespectful. At times, I think you'll lose patients and families, even on the inside, if you're thinking, I'm feeling really rattled here. So I think it's about rapport building, giving them small bits of information and trying to, I suppose, win them over. And eventually people will come around, or between, again, if you're sharing that care with another team, like I'm saying in the hospital, it might be oncology, working with common goals and common communication. It's tricky, I think, sometimes with a family, for example, where you've got one brother that wants this and one brother that wants this and the wife wants this. That's very difficult. I mean, we do have to really abide by, ultimately, if the patient's got capacity to support the patient, and ultimately, ideally, it will be around, otherwise, the primary decision maker. But our best outcome really is that we get everybody on board and everybody comes to a consensus, because ultimately, a lot of sometimes I think when you see this family conflict, it is around distress, it's around grief, it's around love. It all can be seen, to be honest. Lots of families, including my own, have got dysfunction. So then we put people who've got dysfunction into a very stressful situation. And I think that's also, I think, sometimes doing things like giving everyone a bit of permission to have time out, having a bit of a rostering set up at times where people come and go, but being respectful, because I think everybody's got that relationship with the patient. So doing our best, and it's not always easy. Certainly not. Oh, okay. Oh, there's one here about the resources. Yeah, so with the resources, there's lots of local resources, like through Palliative Care Tasmania. But I think also, I'm just saying, things like Care Search is a big one that I use, Care Search through Flinders University. Look, there's some more academic ones, depending what role you're working in, like therapeutic guidelines, which guide you around sort of medicines and best practice. There's lots of stuff online around Googling, and I'm saying having a look at different things, like if you had a particular interest in mouth care or improving end-of-life care at residential aged care, you know, doing sort of literature searches. I think Care Search is very good. I think using your local supports like Palliative Care Tasmania is really important. I would say a couple of other things is that we've got in Hobart, you know, depending if people wanted to be a bit of a palliative care champion, we've got access to things like coming and doing a pepper program, which you can have a look online about, where people come and have a palliative care experience and learn more about PAL care. I think if you work at the Royal, lots of people tap into us. I think residential aged care, again, tapping in with people now, like the CPAP program. What I would say, I suppose, is it's always sometimes limited by staffing and availability, but I think trying to use other resources and online resources are very good. I think the Care Search is a really good start, and I would really encourage lots of fabulous nurses out there to do more. You can do very short courses where you get CPD points, both locally and interstate. And I did my master's, I'm just saying, through Flinders University, and you can start with a grad cert or doing a 6-week unit. And I would strongly suggest, if you're passionate, it will really support and you know, nourish your clinical development, doing more reading, and I'm passionate about that. I think it's really important. Yeah. So I hope that was helpful.
Awesome. And we'll share a link to everyone that's registered and attended today for Care Search, so everyone can kind of get easy access to that. I'm just checking the chat. I don't think there is any other questions. And if there are any questions, happy for anyone to submit them through to PCT, and we'll post them on PalliHub so people can move the discussion over to there after this session. Just wanted to thank you again, Anna, for your time and for your presentation today. I'm sure everyone got something extremely useful out of it. Just a few things I'd like to mention before we head off and everyone enjoys the rest of their afternoon. There is a QR code on your screen. If you could scan that, I will also send you a link to access a survey. PCTC's feedback as a gift. So we'd really greatly appreciate it if you could complete. It is a very short survey. It would only take you a few minutes. So if you want to do it either later today or just in the afternoon, that would be really appreciated. A special thanks to our PCT members that are joining us today. PCT members will be able to access the recording to this session via the Palli Hub. If you're not a member, there will be a link that goes out, or you can scan the QR code to join today. As mentioned before, we'll continue the discussion on Palli Hub. If you haven't already visited the site, it's an online community with over 1,000 members. It has the ability for everyone to connect, engage, and discuss and continue the discussion which we have had today. If you have time, take 10 minutes, just have a quick look at it. We'll also send a link out to this. And finally, we have our Compassionate Tasmanian Palliative Care Symposium coming up in this June. So I'll send out a link for everyone to visit to look at what kind of speakers that we have coming on, the programs out there. So please have a look. It might be something that you're interested in. It is really a great opportunity for you to come together and kind of connect as a sector, to learn and engage and contribute to discussions about quality palliative care and compassionate communities. And it is really targeted for anyone who is working, studying, or volunteering in the palliative care sector, or if you have a really strong interest. Again, thank you, Anna, for your time. I hope everyone has a really great afternoon. Please take a few minutes to yourself to reflect on the presentation, and we'll be in contact with all the resources and links and any other downloads that were mentioned today.
Thank you very much. Thanks everybody for attending.
Thank you.